In the last video, we covered the Women's Health Initiative. That was a 2002 study that effectively ended hormone replacement therapy for an entire generation of women. We looked at what the study actually tested, what it actually found, and the piece of data almost nobody talked about, that the estrogen-only arm of that study showed a reduction in breast cancer, not an increase. Today, we're going deeper, because once you understand that the Women's Health Initiative results were real, but the interpretation was deeply flawed, the next question is an obvious one. How? How did a legitimate study lead to such a catastrophically wrong conclusion about hormone therapy for millions of women? Who needed those? The answer comes down to three specific design problems in the study. And then we're going to go into looking at what happened when researchers went back to the data and when new trials were specifically designed to answer the questions that the WHI could not. Hi, I'm Dr. Greg Oliver once again. Let's get right into it. Now, let's start with the most fundamental problem. The women in the Women's Health Initiative study were not the women who would actually be prescribed hormone therapy. And this is a major flaw. The average age of the WHI participants was 63 years old. 2/3 of the participants were between 60 and 79. And the majority, over 70% in the combination therapy arm, had never taken hormone therapy before in their entire lives. Now, compare that to the actual population of women who seek hormone replacement therapy. Women in their late 40s or early 50s who are currently going through perimenopause, or maybe they're just entering postmenopausal time. Women with active symptoms, women whose hormonal transition is happening right now, not something that happened 15 years ago, which were the women who were studied in this particular trial. This is not a minor methodological quibble. The biology is fundamentally different for these women. A woman who is 51 and 1 year into menopause has a different cardiovascular and metabolic profile than a woman who's 63 and has been estrogen deficient for over a decade. Her arteries are different. Her metabolic baseline is different. Her hormonal receptor sensitivity is likely very different. Now, multiple peer-reviewed critiques of the WHI study, including a detailed analysis published in the Journal of Fertility and Sterility, identified this population mismatch as a central flaw. The study tested a regimen in a population that was, in the words of one critique, predisposed to coronary and cerebral atherosclerosis, or hardening the arteries, because of their age. So, studying hormone therapy in 63-year-olds with potential pre-existing artery disease and then applying those results to 51-year-olds with healthy arteries is like studying the effects of exercise in 75-year-old sedentary adults and concluding that exercise is dangerous for everyone. The conclusion does not follow from the study. The second major design problem is the drugs used in the study themselves. The WHI used two specific hormones. In the combination arm, they used Premarin, which is horse estrogens derived from the urine of pregnant horses, combined with Provera, which is medroxyprogesterone acetate, a synthetic progestin, not a progesterone. These were the dominant pharmaceutical products on the market being used at that time, and they happened to be manufactured by the same company, which made them a natural pairing for a large federally funded trial. But Premarin is not the same hormone as the estrogen that your body produces. Human estrogen, the kind that was circulating in your body throughout your entire reproductive lifespan, is primarily 17-beta estradiol. Conjugated horse estrogens contain dozens of different estrogenic compounds found in horse urine, only some of which are even biologically identical to human hormones. And then there's the issue with Provera, the progestin. Medroxyprogesterone acetate is a synthetic progesterone. It is not the same progesterone. It binds to progesterone receptors, but it also interacts with other hormone receptors in ways that natural progesterone does not. So here's another problem. The distinction matters because the breast cancer signal in the WHI study was almost entirely in the Premarin plus Provera group, not in the Premarin alone group. When you take Provera out of the equation, the breast cancer risk disappears. And what appears in its place in the estrogen-only 20-year follow-up data is actually a protective effect against breast cancer. So the question isn't just, is hormone therapy safe? The question is, which hormones? In what form? Delivered how? And to whom? The WHI didn't test those variations. It tested 2 specific pharmaceutical products in one specific combination, in one specific population, and the conclusions that were drawn for it were then applied to all women undergoing hormone therapy everywhere. And that just doesn't work. That is not how science is supposed to work. The third design flaw is kind of nuanced, but it's still very important. Prior to the WHI study, most of the observational studies that had suggested hormone therapy was safe and even cardioprotective were using cyclic progestin protocol, meaning women took progestin for only part of the month, which mimicked the natural hormonal cycle and rhythm of the women. The WHI used a continuous combination protocol, meaning Premarin and Provera, every single day with no cycling. Now, this had never been tested in a large, long-term trial before. Multiple critics of the WHI noted that the selection of continuous combined therapy, which was an untested regimen, in the words of one published critique, was a significant methodological choice that may have contributed to the adverse cardiovascular findings. And it did that by negating the protective effects of estrogen on the vascular system. So think of it this way. There's good evidence that estrogen has a beneficial effect on the cardiovascular system when arteries are healthy. It helps maintain the artery's flexibility, helps manage cholesterol, helps maintain blood vessel lining function. But when you add continuous synthetic progestin to that equation, you introduce a hormone that can partially block some of estrogen's beneficial blood vessel effects. Again, this is not the same as what women taking bioidentical progesterone cyclically are doing today. And it's one of the key reasons why the modern approach to female hormone optimization looks completely different from what the WHI tested. We'll go deep on that in video 3. For now, the takeaway is this. The Women's Health Initiative tested an untested, continuous synthetic progestin regimen in older women with pre-existing heart vulnerability, and then attributed the results to hormone therapy as an entire category. That is a profound analytical error. And here is where it gets really interesting. Because even within the WHI data itself, without any outside studies, there's a dramatically different story when you look at the younger participants, those who were late 40s, early 50s. The WHI enrolled women ages 50 to 79. When researchers went back and stratified those ages, the results by age, analyzing the 50 to 59-year-olds separately from the 60 to 79-year-olds, what they found was striking. And this is critically important. In the estrogen alone arm, which was Premarin without the Provera, women aged 50 to 59 who were assigned to the estrogen-only arm showed significantly lower rates of heart attack, lower rates of death, and a significantly lower global health index score compared to those who were on placebos. The benefit per one reanalysis translated to approximately 1 fewer major health event for every 37 women treated at that younger age group over a 13-year follow-up period. Now, in that same younger age group, coronary artery calcification, which can be a direct measure of arterial plaque around the heart, it was significantly lower in the estrogen group than the placebo group at the end of the trial. In contrast, the older participants who were 70 to 79, they showed increased cardiovascular risk. The pattern was consistent. The farther the women were from menopause, the less favorable the cardiovascular picture. This was the timing signal hiding inside the very same data that had generated the alarming 2002 headlines. And importantly, a 2025 reanalysis, which was published in JAMA Internal Medicine by WHI investigators themselves, confirmed that estrogen alone or with combination therapy safely reduced menopausal symptoms without raising cardiovascular risk in women aged 50 to 59. The same investigators who ran the original trial are now saying in younger women, this looks very safe. When scientists recognize that a question hasn't been properly answered, the right move is to design a study that actually answers the question. And that's exactly what happened with the timing hypothesis. Two trials are particularly important when we look at this timing hypothesis. The first is KEEPS, the Kronos Early Estrogen Prevention Study. KEEPS was a randomized, double-blind, placebo-controlled trial designed to specifically study hormone therapy in recently menopausal women. The average age was 52, which was within 3 years of their last menstrual period. This is the population that WHI didn't look at. The trial evaluated the effects of both oral estrogen and transdermal estrogen on cardiovascular markers, cognitive function, and other menopausal symptoms. The KEEPS results showed no increase in cardiovascular risk in these younger women, recently menopausal women. Symptoms improved, quality of life improved, and there were no signals of cardiovascular heart harm that the WHI had previously reported in its older population. The second and arguably more definitive trial is called the ELITE trial, the early versus late intervention trial with estradiol. ELITE was specifically designed to test the timing hypothesis head on. It randomized healthy postmenopausal women into two groups, those who were within 6 years of menopause and those who were 10 or more years past menopause. Both groups received oral estradiol, not horse estrogen, but not Premarin, but 17-beta estradiol, the bioidentical form like human estrogen. The primary outcome was carotid artery intimal media thickness, how thick your carotid artery lining is, essentially a direct measurement of arterial plaque progression. Thicker walls mean more hardening of the arteries, more atherosclerosis. After 5 years, the results were very clear. In the early group, within 6 years of menopause, estradiol significantly slowed the progression of carotid artery thickening compared to placebo. In the late group, who were 10 or more years past menopause, there was no significant effect. So this is the timing hypothesis now confirmed by randomized controlled trials. Start hormones early, within the window, and they appear to have a protective effect on the arteries. Start them late in a woman whose arteries have already been estrogen deficient for a decade or more, and that protective window has likely closed. So, importantly, the ELITE trial used estradiol, not Premarin, which brings us right back to the question of which hormones we're actually talking about. And we're going to answer that fully in video 3, my next video. So let's put all this together because I want you to be able to walk away from this video with a clear picture of where the evidence actually stands today and why being afraid of HRT is no longer required. The Women's Health Initiative was a real study with real data, but it tested synthetic hormones, not bioidentical hormones. It tested them in an older population, not women who had just entered menopause. It used a continuous combined protocol that had never been validated in any large long-term trial. And when critics went back and looked at the data carefully, the age-specific findings told a very different story than the headlines that came out suggested. The current consensus from the North American Menopause Society and from the Endocrine Society and international menopause organizations is this. For healthy women under age 60 or within 10 years of menopause onset who have bothersome menopausal symptoms and no specific contraindications, the benefits of hormone therapy generally outweigh any risks. Now, that is dramatically different statement from what most women and many physicians took away from the 2002 headlines about the WHI study. Now, does this mean hormone therapy is risk-free? No. Does it mean it's right for every woman? Again, no. There are real contraindications. There are women for whom other approaches are more appropriate than starting hormone replacement therapy. Individual risk assessment matters enormously. But for many women, perhaps most women in perimenopause and early postmenopause, the blanket refusal that became standard practice after 2002 was not justified by the data. And the women who were refused treatment and who spent years suffering from avoidable symptoms of menopause and postmenopause, who experienced preventable bone loss and cardiovascular decline, they deserved a lot better than what came out of that study. They still do. In video 3, we're going to move from the history and the science of what went wrong to what the right approach actually looks like today. We're going to get specific about the hormones we actually use, which are estradiol, micronized progesterone, and testosterone in women, and why those choices are fundamentally different from what they used in the WHI study. We'll talk about delivery methods such as oral intake, transdermal pellets, injection, and why route of administration matters clinically. And we'll look at the data on testosterone in women, which is one of the most overlooked and under-discussed topics in menopausal medicine. If this video helped clarify the science for you, please share it with a woman in your life who's been navigating this question without good information. It can change their lives. I'm Dr. Greg Oliver. Thanks for watching, and I will see you in video 3. Have a good day.